This week, I did a case study on ovarian cancer. So, the patient is a 56-year-old postmenopausal woman presenting for evaluation of some nonspecific but progressively worsening symptoms. She's otherwise healthy with no known chronic medical conditions or any recent surgical history. Her gynecological history includes early menarche at age 11 and late menopause at age 52, with no pregnancies. She reports that she has no family history of gynecologic malignancies, including ovarian or breast cancer. She also has never undergone genetic testing for BRCA mutations and has not used oral contraceptives. She does not smoke. She does drink alcohol socially, but does not report any abuse and is not currently on hormone replacement therapy. Over the past few months, she's developed persistent abdominal bloating, early satiety, urinary urgency, and mild constipation. She's also noticed a gradual increase in her abdominal size and reported unintentional weight loss of about 10 pounds over the last 3 months. Symptoms such as abdominal bloating, early satiety, and changes in bowel or bladder habits are all common presenting signs in women with advanced stage ovarian cancer, but can often be overlooked as the disease often starts as silent. And these symptoms can also be misattributed to other common GI disorders that can lead to delays in diagnosis. The patient's gynecological and reproductive history places her at increased risk for developing the ovarian cancer. This is because early menarche and late menopause are associated with greater number of ovulatory cycles over a woman's lifetime, which can be correlated with increased epithelial cell turnover and higher risks of DNA damage. Additionally, her nulliparity or lack of pregnancies and lack of oral contraceptive use further elevates her risk. Oral contraceptives are known to reduce the risk of ovarian cancer by suppressing ovulation, and their protective effects increases with the duration of use. Although she does not have a family history of ovarian or breast cancer, approximately 10 to 15% of ovarian cancer cases are linked to genetic predispositions, particularly BRCA1 and BRCA2 mutations, which may present even if there is an absence of family history. On physical exam, her abdomen is noted to be distended, with evidence of shifting dullness on percussion, consistent with ascites. On pelvic examination, a firm, irregular, non-tender adnexal mass can be palpable in the left lower quadrant. She has no signs of jaundice, lymphadenopathy, or pleural effusion. The abdominal findings in combination with the palpable mass in a postmenopausal woman are highly concerning for a pelvic malignancy and particularly ovarian cancer. Based on all her above symptoms, they're most consistent with a diagnosis of epithelial ovarian cancer, most likely high-grade serous carcinoma. This was based on the patient's demographic risk factors, reproductive history, persistent nonspecific symptoms, and concerning physical exam findings. HGSC accounts for approximately 70% of epithelial ovarian cancers and is the most aggressive subtype. It often originates in the fallopian tube epithelium and presents at advanced stages due to the vague early symptoms, such as what she's experiencing, and a lack of effective screening tools. The presence of the ascites, a pelvic mass, and the patient's symptoms strongly support this diagnosis. Initial diagnostic workup would include a transvaginal ultrasound to evaluate the characteristics of the mass. If features such as solid components, septations, and papillary projections are seen, malignancy is more likely. Also, a serum CA-125 level would be ordered. This is not specific for ovarian cancer and may be elevated in benign conditions such as endometriosis or fibroids. The risk of ovarian malignancy algorithm, or ROMA, which combines this CA125 as well as HE4 and menopausal status, can provide a little bit of a more accurate risk assessment for malignancy. If imaging in labs are concerning for malignancy, a contrast-enhanced CT scan of her abdomen and pelvis would be indicated to assess for peritoneal carcinomatosis, omental caking, or liver metastasis. Ultimately, surgical exploration and biopsy are then required for definite diagnosis and staging. Treatment for epithelial ovarian cancer typically involves a combination of cytoreductive surgery and platinum-based chemotherapy. The goal of the surgery is to remove as much of the tumor as possible, including the uterus, ovaries, fallopian tubes, omentum, and any visible metastatic implants. Adjuvant chemo is then initiated post-op to treat residual microscopic disease. And in some cases, neoadjuvant chemo may be given prior to surgery if optimal debulking is not initially feasible. For patients with the BRCA1/2 mutations, PARP inhibitors may also be used as maintenance therapy.